Hi, my name is Dr. Surjit Tarafdar. I'm going to talk about renal tubular acidosis today. Just a single slide explaining the basic pathophysiology behind the three renal types of renal tubular acidosis. So to begin with, when do you suspect that your patient has renal tubular acidosis? Because in your day-to-day life, most of the metabolic acidosis that you come across is high anion gap metabolic acidosis, which you might say, for example, in your diabetic ketoacidosis or your lactic acidosis or even metabolic acidosis due to advanced renal failure. So you suspect RTA when you have normal anion gap metabolic acidosis with either hypo or hyperkalemia, and that's pretty much it. Now, since it's normal anion gap, of course, the chloride will be high. So high chloride, normal anion gap metabolic acidosis with either hypo or hyperkalemia with relatively well-preserved GFR should make you suspect RTA. Now, I said relatively well-preserved GFR. So if somebody, for example, had a GFR of 60 and now has dropped suddenly down to 30, I would be tentative with making a diagnosis of RTA in that context. But if someone had a GFR of 35 and has now come down to 30, I would say that it's relatively well preserved despite the CKD. So as I said, it can come with either hypo or hyperkalemia. So when normal anion gap metabolic acidosis presents with hypokalemia, it's most probably either type 1 or type 2 RTA. Type 1, which is distal RTA, is basically just an inability to excrete hydrogen in the urine. And because the body cannot excrete hydrogen, the hydrogen stays back in the body and therefore you're acidotic. Type 2, which is proximal, is basically an inability to reclaim or reabsorb back bicarbonate in the proximal tubules. So we freely filter bicarbonate in our glomeruli and we reabsorb 100% of that bicarbonate. 90% is reabsorbed in the proximal tubule. So our inability to reabsorb bicarbonate in the proximal tubule leads to proximal renal tubular acidosis. The only other condition which I would like you to think about in the context of normal anion gap metabolic acidosis and hypokalemia is chronic diarrhea. It can present with a similar picture, and we'll discuss about that later on in this talk. Now, when you get normal anion gap metabolic acidosis with hyperkalemia, you're probably looking at a type 4 RTA, which is basically due to either aldosterone deficiency or tubular resistance to the action of aldosterone. Now, this one is the commonest, and between type 1 and type 2, type 1 being distal and type 2 being proximal, remember type 1 is more commoner. Now, before I jump into the different sorts of RTAs, I think we need to recapitulate a little bit of the basic physiology. Every cell in our body, and this applies more on the tubular cells than I suppose any other cell in the body, but essentially every cell in the body on the basolateral side has a sodium potassium ATPase, which is constantly pumping out 3 sodium and it's pulling in 2 potassium. So as you can see, this is the cytoplasm and this is outside the cell. So it's constantly pumping out 3 sodium and pulling in 2 potassium. So as it throws out 3 sodium and pulls in 2 potassium, a few things happen. Firstly, it's low in sodium. Secondly, it's high in potassium. And thirdly, it's negative. All cells are basically negative. The only time your cells are positive are when you're already dead. So to give an example, serum potassium is around 3.5 to 5. Inside the cell, the potassium can be almost 150. And similarly, serum sodium is 130 to 45. And inside the cell, it's around 10 to 20. So just remember, every cell in your body is low in sodium, high in potassium, and it's electronegative. So therefore, it's hungry for positive things and it's hungry for sodium. So continuing with the basic physiology, so proximal RTA, which is type 2 RTA, is an inability to reabsorb bicarbonate in the proximal tubules. So as I said, normally we freely filter sodium bicarbonate in the glomeruli and 100% of it gets reabsorbed. So you don't have any bicarbonate in the urine. And out of that, almost 90% of the bicarbonate is reabsorbed in the proximal tubule and 10% is in the distal parts of the tubule in the collecting duct. Proximal RTA, you are basically unable to reabsorb bicarbonate. It can also lead to Fanconi syndrome. So let's just go to the physiology a bit more to try and understand what causes Fanconi syndrome. So I'm going to use the highlighter here. So this is your proximal convoluted tubule. Let's say you got your glomeruli here, and this is the lumen where you got the urine. And on the other side of the cell, you got the interstitium and the blood vessels, vasa recta. As we said, Every cell on the body on the basolateral side has sodium potassium ATPase, which basically throws out 3 sodium and pulls back 2 potassium. So the cell is low in sodium and therefore it's hungry for sodium. Now the glomeruli is freely filtering out sodium bicarbonate. The cell looks at the sodium and says, hey man, I want the sodium. It just grabs the sodium. As it grabs the sodium, in exchange it throws out an hydrogen, and I'll come back to that hydrogen in a minute. We'll see where did the hydrogen come from. Now as the hydrogen goes out, it sees this negatively charged bicarbonate. It combines with the bicarbonate to yield acetic acid. Carbonic anhydrase, which is sitting on the luminal side membrane of the proximal cell, proximal tubular cell, quickly breaks this acetic acid into water and carbon dioxide. Water goes out in the urine. Carbon dioxide is basically freely diffuses into the proximal convoluted tubular cell, where now the reactions go in the reverse. So carbon dioxide combines with water to yield acetic acid. See, the reactions are basically going in the river, and again carbonic anhydrase is involved here. Carbonic anhydrase breaks now acetic acid into hydrogen and bicarbonate, and the bicarbonate enters into the body, and this hydrogen was the one that initially exchanged itself for sodium. So now you can see in the process of reabsorbing bicarbonate, we didn't exactly reabsorb the same bicarbonate. We kind of broke it, made it an acid, made a bit of carbon dioxide, but then we converted it back to bicarbonate and we reabsorbed it. And at the same time, sodium also got reabsorbed. So if you have a problem here, you're losing bicarbonate in the urine, and as you're losing bicarbonate in the urine, you become acidotic. As you're losing bicarbonate, remember, you're also losing sodium in the urine, and as the sodium goes out, the collecting duct cells, which are like the last man standing in the kidneys, they say, hey man, you're losing too much sodium. So they will try to reabsorb some sodium. But remember, cells are supposed to be negative. So when the collecting cells, duct cells reabsorb sodium, they start to turn positive and they say, oh my God, we're going to die. So we must lose something positive. And what's the chief positive ion inside cells? In every cell in your body, the chief positive ion is potassium. So the cells throw out potassium in exchange, and therefore with proximal RTA, you see hypokalemia. The other thing is, as this sodium is reabsorbed, sodium being the good friendly guy, it takes a few of its friends with it, which are basically glucose, phosphate, amino acid, and uric acid. So if you have a problem here and you're not able to reabsorb bicarbonate and sodium, and as this goes out with the sodium, it drags out glucose, phosphate, amino acid, and uric acid. So you have glycosuria in the non-diabetic guy. You're losing phosphate and uric acid in the urine, so your serum phosphate, serum uric acid would be low, and you're losing amino acid. Amino acids are basically protein, so you will detect urinary protein. So that's Fanconi syndrome. So now we know that proximal RTA is inability to reclaim bicarbonate. Bicarbonate goes in the urine, and therefore you're acidotic. And as bicarbonate goes out, sodium goes out too. And if it's severe, as sodium goes out, it drags with it a few of its friends, which is glucose, phosphate, amino acid, and uric acid. So the patient with normal, if you have the full-blown Fanconi syndrome, you will have a normal and gap metabolic acidosis with hypokalemia, and you will have low serum phosphate and low uric acid, serum uric acid, because you're losing those in the urine, and the urine protein would be high. Now, moving on to the causes, there are quite a few causes here, but I would always like you to think about myeloma first and foremost. So I always say cause number 1 to cause number 10 is myeloma. Over the years, I've had one myeloma patient that sneaked in on me as a Fanconi syndrome, and it took us a bit of time to realize that. So myeloma and other monoclonal disorders like amyloidosis, etc. Drugs, obviously, you could see that carbonic anhydrase is intricately involved in the process. So anything that inhibits carbonic anhydrase, for example, acetazolamide, which is used by our ophthalmology colleagues to treat glaucoma, topiramate, which is used by our neurology colleagues, tenofovir and a few other antiretroviral drugs, sometimes aminoglycosides, and a few other drugs, heavy metals, and a few other conditions, as you can read through that. So that kind of sums up just the causes and the basic pathophysiology of proximal RTA, which is type 2 RTA. And distal RTA is caused by inability of the distal tubules to excrete or secrete hydrogen, and you're acidotic because you're retaining hydrogen. Now, the million-dollar question is, both proximal and distal RTA will present to you with normal and gap metabolic acidosis and hypokalemia. Proximal RTA, we saw that they're hypokalemic because in proximal RTA, the disorder is inability to reabsorb bicarbonate, and reabsorption of bicarbonate is intricately linked to reabsorption of sodium in the PCT. So if you can't reabsorb bicarbonate, you can't reabsorb sodium. Sodium goes out in the urine along with bicarb. The collecting duct cells, which are like the last man standing in the nephron, they think, oh my God, we're losing too much sodium. They'll try to reabsorb some sodium. But as they reabsorb sodium, they start to turn positive, and they know that if they turn positive, they're going to die. So they kick out the positively charged ion inside cells, which is basically potassium. That explains hypokalemia in proximal RTA. Why are people hypokalemic in distal RTA? So distal RTA, we said, is a inability to excrete hydrogen. So again, all tubular cells, proximal tubule or distal tubule or collecting duct, all of them, as you could see, are hungry for sodium. So in the distal tubule, basically, as the cells reabsorb sodium, in exchange they kick out a bit of hydrogen. They need to lose something positive. But because here we have a problem with excreting hydrogen, and that's the basic defect in distal RTA, then the cell says, oh man, we need to lose something positive in exchange for the sodium. So the next best thing that they can lose is potassium, because they're full of potassium. And therefore distal RTA gives you a hypokalemia. But then that brings us to the question of how do we differentiate between proximal RTA and distal RTA? Both will present with normal anion gap metabolic acidosis and hypokalemia. Now I want you to think that if you're acidotic due to any cause, doesn't matter what cause, if you have metabolic acidosis due to any cause, how do you think your kidney will respond to that? So think about that for a minute. The kidney will basically excrete hydrogen. It will just kick out hydrogen like mad. So your urine pH would be low. It will be acidic. Except when you're looking at distal RTA. So what was the problem with distal RTA? The distal RTA, the problem was inability to excrete hydrogen. So if you can't excrete hydrogen, your urine pH is going to be high. So some say more than 5.3, some say more than 5.5. So distal RTA is the only metabolic acidosis condition in your body where your urine pH stays more than 5.5. Any other acidosis, your urine pH will be appropriately low and acidic, and therefore that's how you distinguish between the two causes. The one big cause that you cannot forget is Sjogren's syndrome. So literature says that 25 to 30% of people with Sjogren's syndrome actually have distal RTA. Don't forget lupus. Many of the cirrhotic conditions, chronic liver disease conditions, can give you a bit of distal RTA. Chronic obstructive uropathy, so our urology colleagues I think sometimes come across it. Renal transplant and glue sniffing, which I don't think is practiced now a lot, but probably in some part of the world it still is. Drugs like lithium. Amongst the NSAIDs, I'm not very sure why it's only ibuprofen and a few other drugs. Hyperparathyroidism, vitamin D intoxication, sarcoidosis, Marfan syndrome, and Ehlers-Danlos syndrome. Now, I said that, remember the first slide I mentioned that both type 1 and type 2 RTA come to you with normal anion gap metabolic acidosis and hypokalemia. However, chronic diarrhea can present with normal anion gap metabolic acidosis and hypokalemia. That's because they're losing all those bicarbonate-rich pancreatic secretions, and also their intravascular volume decrease. So renin-angiotensin aldosterone gets activated, and aldosterone, as you know, causes potassium excretion, so they're hypokalemic. So how do I differentiate this from RTA? When I say RTA, it's more of proximal RTA, because between proximal RTA, distal RTA, because between distal RTA and proximal RTA, distal RTA is the one that's much more common in your real life. So the concept of urine anion gap. So urine anion gap is sodium plus potassium minus chloride. Unlike blood, where when we look at the plasma anion gap, we do sodium plus potassium minus chloride and bicarbonate. But remember, in urine, you do not have any bicarbonate. You reabsorb every bit of it. So normally it's positive in healthy individuals. Now, if I'm acidotic due to any cause, doesn't matter whether I've got diarrhea or I've got diabetic ketoacidosis or I've got proximal renal tubular acidosis, what do you think the kidney will do? The kidney will try to excrete all the extra hydrogen. Now, the hydrogen needs a buffer, and out of two buffers, there are two main buffers in the urine, and one of them is ammonia. So as ammonia accepts hydrogen, it becomes NH4+, which combines with the negatively charged chloride to make NH4Cl, and that goes out in the urine. So the point is, if you're acidotic due to any cause, your kidneys are trying to lose hydrogen. Hydrogen needs a buffer. Ammonia being a buffer, it combines with hydrogen and chloride to make ammonium chloride and goes out in the urine, which means your urine chloride will be high, and therefore sodium plus potassium minus chloride, that equation will turn negative in usual acidosis, apart from type 1 RTA, which is distal RTA, where remember the problem is inability to excrete hydrogen. So if you can't excrete hydrogen, you're not going to make ammonium chloride, so your chloride stays low. So urine iron gap is positive in type 1 RTA, as it's positive in normal people. So moving on, bones and stores in RTA. Now, metabolic acidosis due to any cause will cause your bones to break and release calcium phosphate, because calcium phosphate essentially is a buffer. And therefore, uncontrolled metabolic acidosis over a period of time can lead to osteomalacia, osteopenia sort of picture. Again, coming back, you have got metabolic acidosis due to any cause, your bones are being broken because it releases calcium phosphate, which is a buffer. So what do you think the kidney will do? The kidney will say, oh man, there's a bit of extra calcium, so I'll just try to lose it in the urine. So your urine calcium will be high when you have got metabolic acidosis. But thankfully, citrate in the urine keeps the calcium soluble and they go out in the urine. However, in type 1 RTA, which is distal RTA, because you're unable to excrete hydrogen, and the problem is in the distal tubules, so your proximal tubules are fine, the proximal tubules will say, okay, we need to hold back every bit of alkaline thing in the urine. So it reabsorbs not just every bit of bicarbonate, but it reabsorbs citrate as well, which acts as a buffer. So because it reabsorbs every bit of citrate, now the urine doesn't have any citrate, and so the calcium is free. Citrate makes it soluble and goes out in the urine, but if you don't have citrate, the calcium is free and it can precipitate. Therefore, people with type 1 RTA are more predisposed to calcium stones. So a quick recap of the basic differences between type 1, which is distal RTA, and type 2, which is proximal. So remember, type 1 is more common. Type 1 is inability to excrete hydrogen. Type 2 is inability to reabsorb bicarbonate. Type 1 urine pH is more than 5.5 because you don't have any hydrogen in the urine. Type 2 urine pH is less than 5.5 because when you're unable to reabsorb bicarbonate and you're turning positive acidotic, your distal tubules will pump out hydrogen like mad. Now you can argue with me and you can say, okay, but in proximal RTA, if you're unable to reabsorb bicarb, so your urine is full of bicarbonate, shouldn't that make your urine alkaline? And that's a great question. The answer is yes. Initially, the extra bicarb will make the urine alkaline, but the body will quickly pump out a lot of hydrogen from the distal tubules, and so the overall urine pH becomes negative. If you look for bicarb, yes, they will have bicarb in the urine, but the urine pH will be low because of the extra hydrogen. Type 1 more prone to nephrolithiasis and nephrocalcinosis, as we spoke, explained in the previous slide. No renal stones in type 2. Type 1 doesn't have Fanconi syndrome. Type 2 may develop Fanconi syndrome where you have glycosuria in the non-diabetic guy. You got phosphaturia and uric aciduria, so your serum uric acid and serum phosphate is low, and aminoaciduria, which means basically your urine protein is high. Treatment for both, as you can see, is basically treat with alkali and potassium. Now, the only thing I want you to remember is proximal RT generally is a bit milder than distal RT. Generally, not always. So in proximal RT, I think the bicarb tends to be a bit better than distal RTA. Because as the body realizes it's unable to reabsorb bicarb in a patient with proximal RTA, it will filter less bicarb. But the thing is, when you start to treat them, you give them sodium bicarbonate, and the kidney promptly filters that out. So they need bigger doses of sodium bicarbonate. That's the first thing. And the second thing is, when you treat them with sodium bicarbonate, now as they're filtering out, you give them sodium bicarbonate, they filter out sodium bicarbonate, so more sodium goes out in the urine. And as we said, the most distal part of the tubule, the collecting duct cells, will try to reabsorb that sodium, but in the process they will lose potassium. So when you treat people with proximal RTA, A, you need bigger dose of alkali. B, they are more prone to develop hypokalemia as you treat them. So you have to replace potassium pretty aggressively. So again, summing up, type 1, type 2, alkali potassium replacement, higher doses in type 2 potassium. Sometimes if you're having problem with giving them sodium bicarbonate because they just keep dropping their potassium, you could use potassium citrate. You can ask your hospital pharmacy to make it for you. And if there's severe hypokalemia, of course, you either give the potassium prior to or make sure that you keep enough potassium along with the alkali therapy. Moving on to type 4 RTA, but before that, we'll quickly revise aldosterone, because as we said, type 4 RTA is nothing but either aldosterone deficiency or the tubular unresponsiveness to aldosterone. So what does aldosterone normally do? So we said that all the tubular cells are basically hungry for sodium because on the basolateral side they have sodium potassium ATPase. which throws out 3 sodium and pulls in 2 potassium. And therefore, all tubular cells are hungry for sodium and they just keep reabsorbing sodium from the urine. What aldosterone does is it gives a boost to this process. I'm going to use the highlighter. So as aldosterone comes and hooks on here to the receptor, it does 2 things. First, it gets the sodium potassium ATPs to work even harder. So cell lose more sodium, cells are more hungry for sodium. And 2, it goes to this epithelial sodium channel, which is ENaC channel. It basically keeps it wide open. So it draws in more sodium. So A, it's throwing out more sodium on the basal side from the cell, making it more hungry for sodium. B, it actually draws in more sodium. So as it draws in sodium directly, water follows, and both sodium and water into the body. But as it does that, the urine gets really angry and it tells aldosterone that, man, you've taken a lot of positively charged sodium and you have left back negatively charged chloride. I don't like this. I need something positive in return. So then the aldosterone looks at the cell and it says, okay, the cell has a lot of potassium, as we mentioned before. So aldosterone actually directly kicks out potassium into the urine. But I think aldosterone reabsorbs more sodium than it kicks out potassium. So the urine says, okay, you have taken a lot of sodium, you've given me some potassium, but not enough. I need more positive things here. Now aldosterone is not sure of what to do. So in this diagram, I've got these principal cells where aldosterone acts, and this is the collecting duct part of the nephron. So 90% of the cells here are what we call as principal cells where aldosterone acts. 10% of the cells in the collecting duct are not principal cells. They are what we call as intercalated cells, which is of 2 types, alpha and beta. Beta intercalated cell is rich in bicarbonate. I'm not interested in that. Alpha intercalated cell is acidic and rich in hydrogen. I'm interested in that. The alpha intercalated cell, being the good neighbor, tells aldosterone that, look, you've taken a lot of positively charged sodium, but you have not been able to give enough positively charged potassium in exchange to the urine. Now I'm the good neighbor. I've got some positive stuff, which is positively charged hydrogen, and I'll throw it out. So therefore, direct effect of aldosterone is sodium absorption. Indirect effect is water absorption. Direct effect of aldosterone is potassium excretion. Indirect effect of aldosterone is hydrogen excretion. So if you have a problem with either low aldosterone or hyporesponsiveness to aldosterone, so you're not able to kick out potassium, you're hyperkalemic, you're not able to kick out your hydrogen, and you're acidotic. So that's what we are trying to say. Type 4 RTA is characterized by normal and non-gap metabolic acidosis. It's usually mild and hyperkalemia. And I use the word usually because I've seen a few severe cases. It's associated with either hypoaldosteronism, often due to hyperenism, or diminished tubular response to aldosterone, or maybe there is a defect in the principal cells. Remember, I showed you that sodium channel through which sodium is supposed to enter. Maybe there's a problem there. So if it can't get sodium to enter into the cell, it can't kick out potassium, it can't kick out hydrogen. So acidotic and hyperkalemic. So causes, the big fat one I think is diabetes. So if you look carefully with people with long-standing diabetes or poorly controlled diabetes, you will often see that the bicarb runs around that 17-18 mark, and the potassium runs around that 5.5-5.6 mark. But having said that, a lot of these people would be on ACE inhibitor and ARB. So as you can understand, ACE inhibitor, ARB, spironolactone, etc. By ACE inhibitor and ARB will break the renin-angiotensin aldosterone axis. So if you're on ACE inhibitor or ARB, you're not going to make a lot of aldosterone. And again, things like spironolactone will directly antagonize aldosterone. So you can get type 4 RTA. Calcineurin inhibitors, cyclosporin and tacrolimus, those of you who have worked in the transplant unit in the course of your training or are transplant physicians, you know that cyclosporin and tacrolimus can give you type 4 RTA. NSAIDs, IV heparin. So over the years, I've seen a couple of patients who 48 hours of IV heparin in the context of a STEMI or a non-STEMI develop type 4 RTA. Trimethoprim can. It may be seen due to chronic intestinal nephritis of any cause, and for some reason, sickle cell nephropathy causes more of it. How do you treat it? Basically, there's an aldosterone problem, so you replace aldosterone, which means you give them fludrocortisone. But having said that, many of these patients who are diabetic will have a bit of hypertension and a bit of CCF, so it's hard to give them fludrocortisone, which will not only help to get rid of the potassium and hydrogen, but also cause sodium and water reabsorption, so you don't want to overload them. So on those patients, you can actually use a bit of thiazide or loop diuretic. And why you do that? Remember, every diuretic, the basic fundamental way any diuretic acts is it inhibits sodium reabsorption. So when you put people on loop diuretic or thiazide diuretic, you're inhibiting sodium reabsorption in the loop of Henle or the DCT. And as sodium goes out, water goes out. That's a diuretic effect. But as sodium goes out and it again reaches the collecting duct cells, The collecting duct part of the nephron, the collecting duct cells, they say, oh man, losing too much sodium. So they will heroically try to reabsorb some sodium. And as they do that, they realize that they are turning positive, which is not good. So they throw out the main positive ion inside cells, which is potassium. That's half the story. The other half is when you're on thiazide or loop diuretic and your volume contracted, so your renin, angiotensin, aldosterone is activated. And aldosterone, you know, that helps her to throw out potassium and throw out hydrogen. So you can use thiazide or loop diuretic to treat these patients. And I think that pretty much brings me to the end of the talk. Opportunities are like buses, they're always another one coming. Please feel free to ask me questions, post messages if I didn't make sense. And I promise that I'll try to get back to you. Thank you, people, for listening to me.